Anyway, so I'm going to talk about Wolff Parkinson White. And the objectives are to define Wolff Parkinson White, and then understand why these athletes are at risk of sudden death, and then review the evaluation and management of athletes with WPW. So WPW is a spontaneous disorder. It's characterized by an accessory connection bypassing the AV node, which results in the preexcitation. It has a risk of reentrant SVT as well as sudden death. The prevalence of WPW is somewhere between 1 and 3 per 1,000 unless you do a nick of time screening, in which case it's 1 in about 100. So it was first described in 1930 by Wolff Parkinson White, but it wasn't until 1943 that the anomalous bundles or the accessory pathways were identified, and then even later, 1973, when the mechanism of sudden death was identified. It can be diagnosed at any age. This is a distribution from Olmsted County, which is another Mayo study, but it shows you across from infancy to greater than 60 that any age can be diagnosed with WPW, most of whom are going to be asymptomatic. That includes 65% of adolescents and then 40% of individuals over 30. The majority have normal cardiac anatomy, but we'll get into some special instances later. As you saw in a couple of previous talks, the diagnosis is made by electrocardiography. The PR interval is short at less than 120. There's a slurring of the QRS, which is the delta wave, and then there's a broad QRS greater than 120 milliseconds. So before I go into what is WPW, just spend a quick slide on what normal conduction is. So here's sinus node, AV node, and usually there's a fibrous annulus between the atrium and the ventricle, which electrically isolates those two, the atrium and the ventricle, with the exception of the AV node. And so the impulse starts in the sinus node, conducts to the AV node where there's a pause, which allows electrical and mechanical contraction of the atria, and then subsequently the ventricle. And so the P wave, the pause, and then the QRS. So this is the distinction, or the normal conductant pattern. However, when you have an accessory pathway, in this example here, there's a direct communication between the atrium and the ventricle, which bypasses the AV node. So it essentially bypasses that pause, which therein shortens the PR and broadens the QRS, resulting in preexcitation. Just a bit further detail so you understand this. So here's the accessory pathway, and it's innervating the ventricular tissue. And you're talking about slow cell-to-cell conduction, not rapid His-Purkinje conduction. So it actually ripples out from the side of the accessory pathway, cell-to-cell across the myocardium, and that's why you have a broad QRS. So when you're looking at Wolff Parkinson White, it's always a race between the AV node and the accessory pathway. If the AV node is winning, you have normal PR interval, normal QRS. If the pathway is winning, then you have a short PR and a broad QRS. And anything in between those two things are a possibility. So when you're looking at clinical presentation, I said most people are asymptomatic, but there's this concept of asymptomatic or pre-symptomatic. So young athletes, 10, 12, 14, have they actually had enough time to say that they're asymptomatic, or indeed are they about to develop symptoms, at which point they're pre-symptomatic. And then when you look at symptomatic, the arrhythmias, as I just stated earlier, are reentrant SVT and then cardiac arrest and sudden death. And we know that athletes with WPW who are most susceptible to sudden death are those with symptoms. So again, the symptomatic presentation. And just in case you wondered, Meatloaf was diagnosed with symptomatic WPW when he passed out on stage. And so he had a top-ranked album, and he's also Eddie in the Rocky Horror Picture Show. So just so you leave here with some knowledge above and beyond that of just WPW. Just say, Meatloaf, man, WPW, passed out on stage. This is all from Wikipedia. I don't know anything other than that. It's a pretty impressive medical search. But when you go back to what are the symptoms, the first of which is supraventricular tachycardia. It's usually well tolerated. The circuit is down the AV node, back up the accessory pathway, and around it goes. If the atrium goes fast enough, at some point that can degenerate into atrial fibrillation, even in normal hearts. And then more importantly, it's sudden death. And sudden death with WPW accounts for about 1% of the deaths in a long-term registry. And the risk of sudden death with WPW is higher in pediatrics at 1.9 than in the adults at 0.9 per 1,000 patient years. And more importantly, perhaps, the cardiac arrest is a sentinel event and is more common in children and adolescents, meaning they present with sudden cardiac arrest rather than the symptoms of SVT, which are well tolerated. And so when you break down what is required for cardiac arrest, first you have to have atrial fibrillation, And then second, you have to have rapid conduction over the accessory pathway that results in ventricular fibrillation. So what do I mean by that? So if you have a slowly conducting pathway, the ventricular response will be 100 to 150, and that's usually pretty well tolerated, although uncomfortable if you've ever had AFib. However, in the presence of an accessory pathway that's rapid, the atrium's going 300 and the pathway says, bring it on. You go 300, I can go 300. And if that persists long enough, you get ischemia and then you get ventricular fibrillation. So in this example, rapid is 300 beats per minute as compared to the slowly conducting at 100 to 150. And so, as I said, you ultimately result from atrial fibrillation across the pathway, rapid conduction, and then ventricular fibrillation. So as far as the risk assessment is to identify those athletes who are at risk of really lethal arrhythmias. And it's broken down into two components, the first of which is non-invasive measures. That includes exercise testing. John showed us some exercise testing earlier, as well as invasive measures, which are either catheter-based or transesophageal-based studies. So I want to pause here and give you a chance to look at these two ECGs. So looking at these ECGs, can you tell me which of these athletes are at higher risk of sudden death? I would say no. The risk of cannot be assessed by the degree of pre-excitation. So why is that? It seems like it would make sense if you're really broad. Aren't you really scary? It's all based on, it's location, location, location. So if you are a right-sided accessory pathway, you're much closer to the sinus node. Therefore, you're activated more quickly, and you result in a broad QRS. If, on the other hand, you're a left-sided accessory pathway, the time from the sinus node to you is much longer, and you result in a much narrower QRS, meaning most of the activation of the ventricle came through his Purkinje and not the pathway. So in this example, actually, this pathway conducts at 20 milliseconds, which is slower than this pathway at 10 milliseconds. So this one, in fact, is the more concerning pathway. So then what are our tools to distinguish these? The first of which is a non-invasive risk assessment, where you see intermittent pre-excitation, which I like to call now you see me, now you don't. So this is pre-excited, same sinus rate, so the sinus rate doesn't change, which is important, not pre-excited, and then pre-excited. So the off-on suggests that even at sinus rates, that pathway can't conduct fast enough, which you could presume to say in AFib, it's not going to do a good job of rapidly conducting either. The other is probably more specific or more helpful is abrupt and complete loss of pre-excitation during exercise. So the athlete's exercising, at some point you go from fat to skinny. And if that is very abrupt and distinct, that's helpful again to say at typical sinus rates, this pathway peters out, so it's probably wimpy, probably not going to cause sudden death. The challenge with exercise testing, though, is that there's this sort of indeterminate risk. And what do I mean by that? So you have a delta wave here, and the athlete starts to exercise, and they're sweating, and they're breathing fast, and the ECG is starting to degenerate. And you're looking at this, and you're saying, it looks different than that. I think there's a delta wave, but those STs are kind of funny. So it's probably still pre-excited, but I'm not sure. So this is the case of you don't know. If you can't see it extinguish immediately, you can't make an assessment on what is the conduction property of that accessory pathway. As we exercise, AV node conduction gets faster, and at some point it can take over the ventricular activation, and you lose pre-excitation not because the pathway checked out, but because the node got faster. So when you look at the non-invasive, if you're still stuck with I don't know, so you have indeterminate conduction, or you have symptoms, then you actually move on to an electrophysiology study where you put catheters in, you put them into atrial fibrillation, and plus or minus SVT, depending upon if they have symptoms. And so, you do put them into AFib, and you see how fast can it conduct, and you're really looking for these broad QRS complexes, which are manifest of activation over the accessory pathway. And rapid conduction is associated with high risk. And you essentially measure the difference between the two pre-excited beats. In this example, it's 200 milliseconds, which you do math, it comes out to 300 beats per minute. Anything faster than 250 beats per minute is considered high risk. So in this instance, this patient actually has a high-risk accessory pathway. In which case, transcatheter ablation, getting rid of that problem, is the next step. And you have two energy sources. You have radio frequency, it's a higher success rate, and then you have cryoablation, which is safer and has a little bit lower success rate. And obviously, with any invasive procedure, there are complications. So when you look at the management of athletes, it does begin with a complete history for the presence of symptoms. And then evaluation does include echocardiography. 20 to 30% of individuals with WPW have some form of a disease, so it's not the majority, but they're important, particularly hypertrophic cardiomyopathy. I've seen very few Ebsteins who get diagnosed later in life just because they had WPW. Usually you diagnose their Ebsteins and you're like, oh God, they also have WPW, in which case they're going to be an SVT their entire first month of life. But I think what's important is that increased risk of sudden death does occur with competitive athletes, and therefore an athlete with WPW does require a risk assessment. So just to bring it all home, the summary, asymptomatic athlete, non-invasive risk assessment if during routine ECG or exercise there's abrupt loss. You can counsel them regarding risks and benefits of the EP study, but I don't think they need it. But if they're persistent or indeterminate, I would recommend an EP study. And the persistence is interesting because that means throughout exercise you had pre-excitation. Only about 20 to 25% of the time did those kids or athletes who have persistent pre-excitation end up having a high-risk pathway in the EP lab. But you can't tell the family anything about that pathway until the EP study is done. So then if you switch to symptomatic athletes, you really do require an EP study to retain eligibility. And then transcatheter ablation really is reserved for asymptomatic athletes, and then, symptomatic athletes, and then asymptomatic athletes who have high-risk features by EP study, meaning that rapidly conducting accessory pathway. So thank you for your time.